I'm Sarah. I'm one of the Neuro-Oncology CNS team here at King's.
Hello, hi, my name is Lavrador. I'm one of the neuro-oncology surgeons here at King's as well.
And we're going to talk to you today about TMS.
And the way we use TMS in our perioperative brain mapping.
We hope you enjoy.
So, Mr. Lavrador, what is TMS?
So TMS stands for Transcranial Magnetic Stimulation and is a technique that we can use to map some functions of the brain before and after surgery. Mainly, we use this technique for language mapping and for motor mapping.
Okay. And do you want to just show us around the machine to start with,
Absolutely.
perhaps?
So this is a machine that we have here in our brain mapping lab, where we have our software, where we have all the information, the MRIs and the neurophysiological responses that we are monitoring. Also, when we are doing language mapping, we use this screen so the patients can see the images that they need to name and the language tasks they have to perform. And of course, because this technique has an added value when it is navigated, which means we know exactly which areas of the brain we are stimulating, we need to identify the person and make it correspond the person and the patient that we have here with the model that we have in the system. And that's why we use the navigation system with this laser over here and with a person specialized tracker that is fixed at patient's head.
Okay. So where does the patient sit?
So the patient is going to sit here in this chair in a very comfortable position that most of the times we use to mimic the situation in theater. And this device that we call the TMS coil is the one that you use to deliver magnetic stimulation into the patient's brain.
Great, thank you. Mr. Lavrador, why do we even need to do this?
It's a very good question. So imagine that we come to our team with a neurological symptom like a weakness, for example. Your hand is not right, your foot is not right, you're dragging the leg. And if you are diagnosed with a brain tumor, that is probably because that brain tumor is in an area that is important for that movement. And for the treating team, it is important when planning the best surgical approach to your case to know in advance where important structures for the movement of the upper limb or lower limb are going to be located. So as we can see here, every single dot that we have is a positive response. It means that it's an important area of the brain for the movement of either the hand or the leg. And what we can see here on this side is our physiological documentation that that stimulus is actually important and we have to preserve that area in order to maximize your neurological outcome of the surgery.
So we are literally mapping the brain?
Yes, we are. We are mapping the outer shell of the brain, what we call the cortex.
So let's say I have a patient who has presented to us with some leg weakness and we've reviewed their scan in our multidisciplinary meeting. What happens next?
So that patient is going to be reviewed in our pre-assessment clinic.
Okay.
And if we all decide that the best thing and the best way forward is to proceed with surgery, and if by analyzing the first initial scans, we believe that this lesion is close to important motor areas, for example, as in this case, the leg area. In that case, the patient is going to come before surgery. We'll have a specialized scan, a more detailed scan with our team. Then that scan is going to be important in this machine to allow this reconstruction to be patient-centered. And then we are going to perform the mapping here. All this information that we can acquire with this testing, it's going to be exported and we are going to have it available in theater so we can interpret in real time with our intraoperative data.
So any evidence you gain here, you then take to theatre ready for surgery?
Absolutely. So not only the information here is important in a preliminary stage where we want to plan our intervention, but also during the surgery, we use it to decrease the surgical time, to tailor our approach, and to guide us where to put important structures for intraoperative mapping, because all this information is confirmed at time of surgery.
Ah, okay. So, do we only use this before surgery?
That's a good point. Recently, we have started to use this technique as well after surgery. So as I say, our surgery starts here when we map our patients before the procedure. But after surgery, if our patients require rehabilitation because of a highly eloquent lesion they have, for example, if they have a tumor that is very close to an important area for motor function, where it is expected that the patient will require rehabilitation after surgery, we can now start our rehabilitation here with a period of training as well with our physiotherapists, so we can give a boost to the motor function of our patients after surgery and help them so they can get in their best condition to our oncology clinics.
Okay, so how often would you have this after surgery?
Not that often, to be honest with you, because only few amount of patients will be suitable to have this technique after surgery. But our preliminary experience up until now is that they do benefit when it is appropriately used and when the indication is there.
That's really helpful. Thank you.
Okay.
We hope you all enjoyed that introduction to TMS. Now, shouldn't you be getting back to work?
Well, I think it's a good idea.